for 39 years or something like that. But little by little, things started to happen that have accumulated and sort of changed my point of view pretty dramatically. So I'll tell you the first of these stories. It's about a patient. So I was running a medical group in Chicago. It was a great medical group. It was called a staff model HMO anchor. And we were paid just like I described. We were paid a certain amount, and if we could keep you healthy, then we made more money. If we screwed up, we lost money, and we actually were able to do it pretty well. So there was one office of our 10, I think, that we had that was the best office. If you had an opening, you got a colonoscopy. if you needed a mammogram, you got everything preventive we could think of. It was great at that. Our patients loved it, and indeed, with all of this great preventive health care that we were doing, we made money. It was profitable. And then this one guy came in. Oop, there he is. It's not actually him. I don't have a picture from 1970, whatever. But that's this one guy. He had hemophilia. So what? So hemophilia is a condition where you don't form clots, where you tend to bleed more. And it turns out it's incredibly treatable. And so treating him was something that, of course, we had to do at the cost of $1 million a year. That's what it cost him. Probably it's way more than that now, but $1 million a year to treat this one guy. Well, this little office into which he went, they couldn't pay for that. They didn't have that kind of money. If we didn't come up with some other solution, they would have gone bankrupt. That clinic would have had to close. And so we didn't act on it, but what it dawned on me as the medical director there was, despite all of those vaccinations we gave, no matter what you think about that, despite all of the preventive care that we did, this guy, by himself, taking care of him, could close our office down. And so what we should really do, from a business perspective, we should make him not like us. We should start being a little more rude to him. We should call him by his first name if he doesn't like that. We should not answer the phone, put him on hold more. We should do things to make him stop really wanting to come to us. We didn't do that. We figured out another solution, but it really aided me that the business imperative on my medical group was to make a patient not want to see us. It can't be the right way to set it up. So things like that kind of accumulated, and more experiences. And that particular story, turns out it's an old story in my life, but it turns out it's incredibly current. That's still exactly the dynamic that insurance companies have today. And to prove that to you, here's a current ad. Have you seen this ad? It's an ad for an insurance company called Everest. So like, Mount Everest, and it's got these people that are doing whatever it is that they're doing. So it's an ad that seems like it's to attract, healthy people, So if you unpack their ad, if you look closely at it, there's actually in fine print a list of things that aren't covered. And I swear to God, I'm not making this up. It doesn't cover mountain climbing. It doesn't cover mountain climbing. So, the ad is designed to attract people, but not pay for their health care. And actually somebody questioned the people from this insurance company about that ad, and they said, well, mountain climbing is excluded, but this isn't mountain climbing, these are people hiking. So they actually thought that. Okay, so we're talking about a solution that I'm submitting to you. The best strategy is a solution built on Medicare. So the question is, of course, why Medicare? A single payer means one payer, but that one payer could be Medicare, or it could be Medicaid, or it could be the VA, or it could be Everest. You could give all the patients to Everest. Why Medicare? What's so great about Medicare? And I tell you that there's 4 things that are really important about Medicare that makes each of us really want to have it, I think. One is it puts you in control of your own healthcare decisions. A second thing is that it eliminates a lot of the waste. And as you know, part of the crisis we have in healthcare today is because of how expensive it is. A third thing is it makes us live longer, and a fourth thing is it's fair and equitable. And I'll show you some information about each one of these points. But to start this, I need to tell you my second story, and you get to meet my family. And I have, if there's any HIPAA police here, I have their permission to tell you the story. So the story starts with my mother-in-law, and she's cute. So I only really do these talks because I love seeing my mother-in-law like that. If you tell me a mother-in-law joke, I won't laugh. I don't understand them because she's terrific. She lives in Florida. She's going to turn 90 in May. And Ma, I have her permission to tell you that, Ma has a genetic condition in her heart, a rare genetic condition in her heart. And it's one of these things that doesn't act up typically, doesn't manifest until sometime in your 70s or so, and that's what happened to her. She developed this heart problem in her later years now, and it gets more and more progressive and would kill her. But there's a treatment which nobody in Florida, where she lives, has skills doing. It's a rare thing. So her treatment, we wanted to get her treated at one of the 3 places in the country that knows how to do this, and there's one in St. Louis where I live. So we flew Ma from Florida to St. Louis. She spent about a week at a terrific hospital in St. Louis, got this wonderful world-class care, recovered for a few weeks and went back to Florida and didn't pay a penny. Ma has Medicare. So let me explain why she didn't pay a penny. Medicare, you may not know, is imperfect, and yet we're still talking about it. Medicare is imperfect. In particular, Medicare comes with pretty significant copays and deductibles. That's one of the things we intend to fix when we expand it. But Medicare today has pretty significant copays and deductibles. 20% of your hospital bill, for example, with no limit. So if you have a $1 million hospital stay, you're responsible for $200,000 of that hospital stay if you have Medicare. As a result, seniors who haven't come up with a strategy about this are still declaring bankruptcy despite having Medicare. So a third of seniors don't have a strategy. Another third of seniors actually buy what's called a supplement, which is what I've done. I've had Medicare for 2 months now, so I'm an expert. They buy a supplement, and a supplement does just that. It takes Medicare, where you can go to almost any doctor in the country, and it just gets rid of the copays, or almost gets rid of the copays and deductibles. Otherwise, it's still Medicare. So that's great. She had that. She could come to the hospital in St. Louis. Now, she had another choice. I said a third of seniors don't do anything about this copay problem, and a third of seniors do a supplement. But another third of seniors do something, frankly, completely different, and that's called a Medicare Advantage program, which some of you have. So Medicare Advantage, in my mind, deserves neither the word Medicare nor the word Advantage. So Medicare pays the hospitals and the doctors directly. Medicare Advantage pays an insurance company, Humana or Blue Cross, and then the insurance company pays the doctors and the hospitals. Why is that important? Number one, it's a middle person, intermediary. It's expensive. Number two, they then manage you as they want to. So they then have lists of doctors and lists of hospitals which they can change as they wish. And I promise you, if my mother-in-law had gone to an Advantage program instead of to a supplement, we would have had to pay full retail to bring her to St. Louis. And her bill was, I'm sure, more than $100,000, and that's a lot of, most folks can't do that. So she doesn't have an Advantage program, she has a supplement. So anyway, Ma has Medicare, as a supplement, to go to any doctor or hospital that she wants to, and if you talk about messing up her Medicare, you got to deal with this. You don't want to do it. So it gives you a good choice. Medicare also means we stop wasting our money. So here's the overhead of the larger insurance companies. Any of my slides that have numbers on them, as this will momentarily, there will be a footnote at the bottom, which will be too small for you to read, but it's there so that if you just have to know my source, I can tell it to you right now. It's not a hidden source. So here's the overhead of the larger insurance companies, 15 to 20%. Does anybody know what the overhead of Medicare is? 3%. Ballpark, it's 2.2. Depends how you look at it, but 2.2%. And it's not magic. It's because the private insurance companies advertise on TV. They have I think 400,000 or 500,000 staff managing the healthier patients. Medicare itself has 4,000 or 5,000 patients or employees. There's a lot of overhead. They do all these call centers. They say no to things. They do underwriting. They do a lot of stuff that's expensive, and they have ginormous salaries oftentimes. So the only way to get to that 2% overhead instead of 18% overhead is to use a program like Medicare. And in addition, makes us healthier. So, sorry about that. So this is my wonkiest chart, and I apologize that it's wonky, and it'll be less wonky for the rest of the evening. But this is also, I think, the most important chart, so bear with this. This is our mortality rate by age compared to 17 peer nations. So you didn't need me in here to tell you that Americans are at the bottom of this chart, right? Americans have 2 or 3 years shorter life expectancy than the rest of the modern world, despite our spending double what the rest of the world spends. So here we are, happily cruising up the bottom of the chart. There we are, at the bottom of the chart. You kind of expected that. Here's what you didn't expect. When we turn 65, look what happens. Country by country, year by year, we climb to the top. We climb to the top, country by country, year by year, once we turn 65. So obviously that's, I think, Medicare, but that also means we should be hugely proud of what we have here. Our delivery system, we simply must have many of the world's best doctors and hospitals and nurses and such, or we couldn't possibly recover from worst to best as we do there. So we should be proud of it. The problem, of course, is we just don't let everybody in. That's, of course, the problem. So it turns out that this is not the same for everybody in America, and I want to focus a bit, if I could, on the African-American experience in healthcare in the United States. And let me be really clear, I'm not African-American, in case you didn't notice, so I don't pretend to be even remotely expert at this topic, that's from that point of view. But here's a very interesting thing. Look at the difference in life expectancies, white versus black. Across the US, it's about a 4-year difference, and I was hoping I would find out that in California it was better, but I didn't. It's actually worse in California. And it turns out that what do people die of? What is it? What are the causes of death that accelerate that shorten the life expectancy? What is it? And it turns out that some of it, of course, because of the demographics of our nation, is from homicide and violent issues. But it turns out that's actually the smallest piece of the difference. The rest of it is heart disease, cancer, strokes, and all that. In other words, almost all of that 4 to 5 year difference in life expectancy between African Americans and white Americans, almost all of that is stuff that we can treat, stuff that we know how to largely prevent, and we can treat, you know. But so what's up with that? Is it getting better? So it turns out African American men, I don't have by gender data, but African American men have had improvements in life expectancy in the last several years, so it's getting better, right? Turns out white men have also had improvements. But the really interesting thing is if you look around the world and look at look at black men elsewhere in the world, they actually track white men here. So this isn't genetic, as some people would want us to believe. This is entirely based on either the experience of being in America or on health insurance differences. It turns out your insurance varies with your race. It turns out African Americans and white Americans don't generally, as a population, get the same insurance. We don't. So non-elderly underinsured, much more likely for blacks in America to be uninsured. And the same is true in California, although not quite as much. So that's peculiar, or maybe it's not. So what happens if you control for insurance? Which of course is leading me to one of the arguments for Medicare for All, is the impact it has on the manifestations of some of the social determinants of health. What happens if you control for insurance? So we know that African Americans are more likely to die after a heart attack and more likely to get a heart attack. We know that. It turns out that if you look at it, it's about 31% more likely. And if you control for insurance, it turns out that almost disappears. If you look at African Americans and white Americans that have the same insurance, just showed you that we don't, but that have the same insurance, most of that difference disappears. It turns out on dialysis, African Americans live longer than white Americans on dialysis. And again, once you get onto dialysis, we all have the same insurance, Medicare. Control for insurance and the life expectancy doesn't just disappear, it actually reverses in dialysis patients. Same thing in the VA. African Americans in the VA live longer than white Americans using the VA. And it turns out as we age into Medicare, that huge difference in life expectancy actually quickly attenuates too. So, of course, single-payer Medicare for All is not going to put an end to the racism that's rampant in our country, but it will make a difference on the differences, on one of the more important ways, in my mind, that it shows up, differences in life expectancy. So there's also an important impact on women's health that isn't quite recognized. We all know that the ACA outlaw differences in insurance for men and women. They can't start. So it turns out that they're still not the same. There's a lot of advantages. Here's things that are covered now for women's health that didn't used to be sort of covered without copays. That's good that they're covered. But it turns out it's still not the same. If you look at industries that are largely female versus industries that are largely male, workforces that are largely men versus women, it turns out that the deductibles between the two groups are different. Women, industries that have women tend to have the largest deductibles, despite the fact that the ACA made gendered, so it's not based on gender, it's based on your industry. Larger deductibles in women-based, in female-based areas. Larger family deductibles, again, in female workforce, and fewer retirement plans in female-based, retirement health plans. So we've kind of made progress, but we have a long way to go. So I'm just going to read this quote to you from John Meacham. What's the lesson of the 20th century? Should we be incremental? Should we take a big step? What's the lesson? What do we learn from all the social changes that have legislatively been produced in the 20th century? Social Security, the GI Bill, Medicare. You got it if you turned a certain age or if you survived in an explicit way. The history of the 20th century is that bigger social policies work better. They're easier to rally behind, they're easier to adopt, they're easier to observe, they're understandable. You know, turn 65, you're gonna get Social Security. You know, that's kind of the whole discussion. That's all you need to hear, right? So that's one of the lessons. But it turns out it's kind of complicated. Does anybody recognize this? Let me get him off the screen, I can't stand it. So, sorry. Okay, my organization, Physicians for a National Health Program, is nonpartisan, 501c3. All right, I won't say anything. So how does healthcare work? Here's all of us, here's all the stuff we want. We want doctors and hospitals and nurses and all that. And of course, between us is the money, right? And the money today is managed by payers. So there's, the federal government pays for the healthcare for the military, for the post office, for, all the things, Medicare, half of Medicaid. That's the state of Missouri. Now you all know that. So the states pay for things. That's one of the schools in Missouri, businesses, St. Louis business, welcome to St. Louis. So these are all called payers, right? So our system today is what's called a multi-payer system, and this complexity is expensive. Complexity is always expensive, and the complexity corrodes quality, and the complexity leaves gaps that people fall through. So this is today's system. We're the only country that organizes healthcare finance in this way. And what I propose to you is we should get rid of all that. Oh, and so here's how this works. We each pay each of those companies a certain amount, so there's complexity there. Then they each have to have contracts with each of these things. It's a mess. This is how it works, and this is the really simplified version of how it works. It's a mess. So how could it work? You could get rid of all that and just have us pay into the federal government through our taxes, and we'll talk about specifically what that would mean. And so that's what a single payer means. That's the idea of a single payer, one payer. And my proposal to you is that the most sensible way to have one payer in the United States, that would be Medicare, improved Medicare. So what does that mean? What is improved Medicare? There's a couple major things that need to be improved about Medicare. The first is, of course, what I started with, the copays and deductibles. So when you hear us saying improved Medicare for all, one of the most important things is to get rid of those copays, get rid of the deductibles. Not cost anything when you go to the doctor, not cost anything when you go to the pharmacy, not cost anything if you have to go to the hospital. Get rid of the copays, get rid of the deductibles. And if you do that, then there's no longer a market for a supplement or for an advantage plan. So first thing, there's a number of things, I want to talk about two. The first thing is improve Medicare by getting rid of the copays and deductibles. The second thing is there's important things that Medicare doesn't cover that it should. Medicare doesn't cover dentistry. And I'm here, let's try this, because I don't know what your interest is going to be. Raise your hand if you think dentistry is more important to you right now than medical health. Some, yeah. I thought it might be the other way, but people really value dentistry, and dentistry impacts the rest of your health in ways that are beyond scope for today. So cover dentistry, give eyeglasses to seniors, give hearing aids to people with Medicare. There's about 15 of these things, expand the benefits. So that's what we mean among other things, by improving Medicare, and then expand it, give it to everyone, give it to Congress, give it to the president, give it to, put everybody in the same program. Let the legislators be in the same program, so if they screw it up, they've screwed it up for their family and themselves. Have them be in the same program. Give it to school teachers, give it to kids, because then, every few years we have these fights about, are we going to expand the health care for kids? 60% of kids are on this S-chip program. Are we going to expand? Stop having those fights, put them in the same program. Give it to low-income people and high-income people, and then you don't have to figure out who somebody is. You don't have to worry that they're bouncing in and out of the right income level, and we don't have to have these ridiculous, my state has not yet expanded Medicaid. Go figure. So we wouldn't have those fights because everybody would be in this program. It's not just to be nice. That's the only way to get from those scary big red 18% overhead bars down to the sweet little 2% overhead. That's the only way to do it. You got to get rid of them, have everybody in that gets us there. That's the best, not the only way, but that's the best way to get the country able to actually negotiate the prices of drugs down to where the world prices are. We pay double for that. Our prices are double. So that's the best way to do that. It creates a large risk pool, which if you're an employer would really matter quite a bit. So, cover everybody, and the bills actually say every resident, not every citizen, every resident. So cover everybody, no co-pays, comprehensive benefits, see any doctor, reduce the nation's costs. How in the world can we afford this? So I told you my background included working within industry at Express Scripts, the economics of this. I would not be on board talking about this if I didn't think this made sense economically for the nation and individually for individual finances. So let me walk you through that. There have been literally 29 studies. Literally, I counted them. There may be more that I missed. Literally 29 studies by different economists that have shown that the economics works for the country. The economics simply work for the country. 29 of these studies, they all say, of course there's new costs, but there's new savings. And that the new savings for the country are at least as high, if not even higher, than the new costs. So there are now 3 that disagree with that, and I'm going to high level kind of point them out to you. But there are 29 that say this. And I'm going to walk you through just one at a very high level. So this one says, of course, there's new costs, but there's new expense, new savings. The new costs are primarily because if we give people insurance, they're going to get health care, right? They're going to go to the doctor, they're going to get the glasses, they're going to get the hearing aids, they're going to do stuff. So that's what the new costs are. This estimate is one of the higher estimates, says there would be about a 12% increase. Now, I said that there were 3 studies that didn't come to this conclusion. One of those studies literally stopped right here and just said, well, there's new costs. We can't talk about it. It's ridiculous, it's stupid. Well, there is another side to this spreadsheet. There's new savings. So what are they? First, it would obviously be less expensive to run one program than to run the hundreds that we run today. Secondly, we would be able to negotiate the prices of drugs. So that 6% is a 40% discount on the 15% that we spend on drugs, or 6%. So that's the arithmetic of that. So the country would reduce healthcare expense by 6% for negotiating prices. We know that hospitals charge different amounts for the same thing, maybe 10 times as much for the same procedure, not based on quality. So there's a savings if we control that and some fraud and abuse. Okay, so if you probably noticed, those things on the right-hand side, those don't actually fund a program. So how exactly do you fund a program? So the first question, of course, is how much do you need? And I'm going to get kind of heavy on economics for about 2 minutes here. But I think that's really important because that's the first thing you hear is we can't afford it. Comment, stupid. So how do you fund this? Well, first question, of course, is how much money do you need? So in 2017, this isn't controversial, how much money do you need? The number that I'm going to show you for this is actually the same number pretty much from the Koch brothers to the RAND study to almost any study. They're in the same ballpark numbers. So how much do you need? Last year, 2017, we spent $3.24 trillion as a country. If you increased utilization by 12%, you would have needed $3.6 trillion, but the savings that this model proposes. So we think we need about just under $3 trillion, $2.93 trillion. So look at this for just a minute, if you would. $3.24 trillion to $2.93 trillion. In other words, what's that? $331 billion savings? Okay, how many walls would that be? We shut down the government for $5 billion, and here's $330 billion that we're not yet pursuing. So, okay, so how do we come up with that? I'm going to show you a possible way to do the taxes on this. Of course it's taxes. I'm going to show you one, this proposal that I'm going to show you is just for, it's for the arithmetic, frankly. It's not, these numbers are published in the same analysis that I just showed you, so I'm not making them up, but they're not in a bill. Nobody's actually proposing this scheme, and I'm not proposing this scheme. This isn't the way I would recommend doing the taxes, but I'm showing you this model because I think you'll come to the conclusion that I have, which is that, you know, if we do a little of this and a little of that, actually nobody has to kind of go crazy bad on it. You know, there are arithmetic solutions to this. So what is this? Here's one of them. The first is continue the current public funding, which is about $1.88 trillion. So don't change that. The taxes we spend on healthcare, that would continue. Health businesses, as you probably know, are one of the larger funders of healthcare today, in a sense. You know, that comes out of their overhead for paying for employee benefits. So this would not give them a windfall. They don't get to like stop paying for healthcare overnight. Maybe eventually you would want to do that, but under this arithmetic, that doesn't happen. But under this arithmetic, they would overall reduce what they spend on healthcare by 8%. So that right off the start helps businesses. So an 8% drop, not 100%, 8% drop. A sales tax of 3.75% sales tax on non-necessities, not clothes or food. I'm personally really not fond of sales taxes. It's regressive. It's not my, but that's not the point. The point is it's 3.75% sales tax. It's not 15% sales tax. Again, I'm not proposing it. I wouldn't defend that number, but it's not 15%, 3.75%. A 0.38% tax on net worth over $1 million. So that's not, 90% tax the rich. This is 0.38% on more than $1 million of net worth. Again, I'm not proposing it, I'm just saying that's a really tiny number. It's a really tiny number. And then lastly, a tax long-term capital gains as if they were income, which they are. So if you did, and that's the smallest number, that's the number some folks are the least happy with, but if you notice, that's kind of the smallest number anyway. So all of these could be negotiated, and if you did that, we would have more money than we even needed in this model. Again, not proposing this set of taxes, just saying, not really horrible, right? I mean, kind of, reasonable. And if you did all this, on average, most American households and businesses would overall pay something on the order of 10% less. You pay more tax, right? But you wouldn't pay any premium. You wouldn't pay any copays. You wouldn't pay any deductibles. You wouldn't risk getting sick in Florida when you live in California and not having it in your network and having to pay full retail. It would be safer and more secure peace of mind. You would get healthcare benefits. So, turns out the rest of the world has done this. This to me is the most important part. Of course we can do this. Here's what several other modern nations spend per person per year on healthcare. Total, here's what the United States spends out of our public tax dollars, and then here's what we spend on private. So we're spending double. And I happen to be a pretty proud American, I'd say that proudly, and I think American exceptionalism means, oh my God, we can do at least as well as the rest of the world, and of course I think we can do better than the rest of the world, and we're not there yet in healthcare, so we have to get there. So of course we can do this, and as a matter of fact, here's one of my favorite quotes. If we can pay for the way things are, we can pay for something that costs less. Gary Friedman, and every economist everywhere. Okay, so it's also really important that this is, to me, actually the most important part about it, is that if you did this, suddenly the country would benefit from improving the country's health. The country would benefit economically from improving the country's health. So let me tell you this story, because this is not the way it is today, but I thought it was. So when I was back working within the insurance industry, there were 3 stories, this is the third one. When I was working within managed care, we noticed, our little group, that we had a lot of people with heart failure who were getting readmitted to the intensive care unit over and over again. Like every 3 or 4 months, these same little cadre of people with heart failure kept getting readmitted, and that was enormously expensive. Right? So I thought, this is great. This is why I believe in this model of insurance, because I have a vested interest in making sure we fix this. So we did. We put in a really expensive program to fix it, though. We bought scales. I think they were like $10. for everybody. Turns out if you give people a scale, that's one of the most important tools. We had a nurse call them once in a while. If we did these really minor, easy things that weren't expensive, we reduced our hospitalization readmissions from heart failure by 50% in 9 months. 50%. We cut heart failure, and that's not just, nice and economic. I mean, that means that they were probably living longer, except we didn't have data long enough. They were probably living better. Wonderful thing, exactly what I thought we should be doing. And then, the insurance company that I was working for that did this was half owned by the hospital that these people were being admitted to. And I'm not making this up. I lived through this. The hospital came and said, hey, our ICU's empty. What are you guys doing? Fill it up again. And they made us stop the program. Seriously. So that was another one of these little bricks building in my head saying, oh my God, this is screwed up. So we had to stop the program. And so we did that. So that's what I'm saying, that having everybody in the same insurance program aligns the nation's economic business interests. That's not an imaginary theoretical thing. That's this kind of program. And if you think about it, there's all sorts of issues with this. So and every time we fail in one of the social determinants of health, every time we fail, it's a disaster for the country culturally and socially and humanly, economically too. So I'm not a master of this, but here's the sort of genres of social determinants of health. And the beauty of a Medicare for All program, of a single payer program, is if you invest on this side, it pays off on the other side. So the same people that would be paying for it would be reaping the economic benefits of it. So that's one of the reasons I think this is so incredibly important. Okay, so Medicare. Is it popular? Is it not popular? Well, first let's see apple pie. Raise your hand if you like apple pie. If you want some apple pie right now, maybe have ice cream on it, right? Yeah. What if I told you it was going to be tasty? Really good apple pie. If I told you it was homemade apple pie. Okay, yes, yeah, sure, right, yeah. How about, keep your hand up if you like it. Now, what if I told you that it would cause obesity and diabetes? What if I told you that it was going to cause heart attacks? What if I told you it had poison in it? Still, you want it? Yeah, what if I told you that? Yeah, sign me up. What if I told you it was $5,000 for a slice? My point of this little tangent is that how we ask the question determines what answers we get in a survey. So if I said to you, do you like apple pie if you knew it had poison? No. You'd say no. Okay, so bear that in mind, and let's look at the surveys about Medicare for All. How popular is Medicare for All? Because I'm here to tell you these surveys are really kind of tricky to look at. And let me show you how they start. So, would you like Medicare for All if you knew that it would guarantee health insurance as a right? Well, turns out in this survey, most of us say, yeah, that sounds good. What if I told you that it would eliminate your premiums and reduce your out-of-pocket costs? Yeah, sign me up. I like these ideas. That's great. Okay, what if I told you that it would eliminate the private insurance companies? Now, if that's all I said to you, which is how the survey was written, what if I told you that it would eliminate private insurance companies, and I didn't tell you that you wouldn't need them because you will reliably have something better? If I didn't tell you that stuff, no. And that's what you're seeing in the media now. You're seeing, well, when you tell people that it's going to eliminate private insurance companies, they're not as popular. They're understanding it now. No, they're being misled now. What if I told you it's going to cause your taxes to go up? Well, no. Again, not saying, but you'll actually spend less because you won't have a premium. You won't all the stuff we just went through. The question matters. What if I told you that it was going to threaten Medicare as we have it today? Yeah, it's going to change Medicare because it's going to add dentistry. It's going to add pharmacy to everybody. It's going to add these things, and it'll stabilize it because everybody in the country will be in it. So if I told you it's going to threaten the current Medicare program, and this is so important to understand because you're seeing all over the news now that people are not as fond of Medicare for All because they're understanding it better. No, they're misunderstanding it. This is what the opposition does. They actually have a word. They call it FUD, F-U-D. Have you heard this? PR folks in school learn the word FUD, F-U-D, fear, uncertainty, and doubt. That's what they do. They aggressively organize campaigns around creating fear. Oh, it's going to threaten Medicare. Uncertainty. You may not have insurance. Doubt. I don't think they know what they're talking about. Fear, uncertainty, and doubt. There are campaigns, organized, PhD level masters of this stuff, of communication, organizing how to spread fear, uncertainty, and doubt. That's what this kind of push survey really is. Politicians actually don't understand how popular this stuff is. So here's a chart looking at if the actual support in hundreds of congressional districts for Medicare for All versus politicians' estimates of what that would be. So if politicians actually understood how popular it was in their district, they would come up with that line, right? Because 60% popular in the district, the politicians would estimate it as 60% popular. Well, actually, it turns out that even Democratic, even liberal politicians underestimate it, and even conservative politicians underestimate it even more. So it's up to us to raise our voices about that. Single payer for Medicare for All is not the only choice. There's many other choices, but I submit to you that it's our best choice. So I want to walk through one decoy choice. Incredibly important. This is, I submit, if all y'all, that's a Missouri phrase. You know what all y'all is? That's the plural of y'all, you know? All y'all. Now you know. So isn't that a nice phrase? All y'all. If all y'all, you have to understand this. It's really important because this is how, if we're not all raising our voice about this, we're going to be misled. So let me explain this one piece, the public option. And it has a number of brand names these days. So I'm calling it the public option. It's also almost identical with the phrase Medicare buy-in, which has now brand names in Congress. There are variations on this: Medicare Extra, Medicare for America, Medicare X, Medicare. I don't know, there's like 6 or 7 of these that all have at their core a public option, and then some have some actually, frankly, better features than others, but they all have this as their core strategy. So let me explain what a public option is, because all y'all need to understand it. And when politicians say that they're running for Medicare for all, you need to figure out if they really mean this, because this is quite different. So what is a public option? It's basically, give it a price. If Medicare is such a great idea, doc, well, let us just price it, put it on the market, have a premium rate for it, put it on the market, and if it's such a great idea, let the hidden hand of the free market work, and Medicare will take off. Everybody will buy that, and Cignas of the world will just disappear, and the free market will have raised its one-fingered hand again and solved the problem. So let Americans under 65 buy into Medicare is the concept there. Some plans would also say employers could switch from offering private insurance to Medicare, and it's basically a free market concept. And if you're a free market person, that has inherent appeal. And the other idea about it is that it would be less abrupt. It's more of a transition project, and we could get there without as much political capital. And that logic depends on nobody in this room telling anyone in the insurance industry, we're doing this because we want to get to Medicare for all, so don't let them know that, right? That's the strategy. So it sounds tempting, and actually a few years ago I would have maybe supported it until I learned more about it, which is that there's another side to this story. The first thing is that you miss most of the savings. You're just adding another insurance company, Medicare in this case, to the marketplace. So those giant red 18% bars of scary overhead, that doesn't go away. If anything, the system is now one notch more complicated. So most of these plans miss most or all of the savings. It's not going to draw in a lot of the uninsured. The uninsured are uninsured today largely because they've made the decision that healthcare is just too darn expensive, and it's not a good buy for them. And so we would just have one more option that probably wouldn't be all that much cheaper. So we'd still be left probably with tens of millions of uninsured, which is, of course, one of our bigger problems. It would mainly create a high-risk pool, which would become increasingly expensive. It wouldn't do anything for the people that today have $6,000 and $12,000 deductibles, and that's pretty common. It wouldn't do anything for them. It wouldn't really improve Medicare. It wouldn't mean Medicare now has dental benefits. It wouldn't really do anything. And more importantly, if we let Congress make this the fight, oh, we want Medicare for all, but we think the way to get there is through a public option. If we let that become the fight, it's going to take 3-5 years before we get the public option, right? It's not going to happen quickly. It's going to take a change of Congress. It's going to take 3 to 5 years before we accomplish this step. And then you try to talk about healthcare reform or Medicare for all with people 5 years from now when this thing passes, they'll look at you here. They won't make eye contact because they'll be saying, I'm really worn out. I'm really worn out. Let's give this 3 to 5 years to work and see how well it works. In other words, this would probably delay Medicare for all and single payer by 5 to 10 years if we let this become the fight. So it's incredibly important when you hear people running for office saying, I'm for Medicare for all, and I think the way to get there is through a public option or through Medicare Extra or one of these other things. I think the way to get there is through that. You need to go to the town hall and raise some of these concerns about, well, why is that such a great idea? Why don't we just do the right thing that we know most Americans want? Why don't we just do the right thing? So you need to really understand that. It turns out there are now 2 bills that actually accomplish this. There's one in the House from Representative Jayapal and one yesterday, so new slides, from Senator Sanders. So they're very similar. That's probably the most important thing, is that the bill in the House and the bill in the Senate have a lot more in common than they have that distinguish them. The bill they both say comprehensive health care for everybody who's a resident of the United States. Neither of them say for citizens. They both say for all residents. They also both say, and the Department of HHS would need to put some language around that. So it wouldn't be, you can come across the border on Monday and Monday night, you would have Medicare for all. There would be some language around that which would be developed in the regulations, and that would be really important for us to track and advocate around. But some language, but in general, it's not a citizenship requirement in both of these proposals, it's a residency requirement. It also would, obviously, both bills will let you choose any doctor, would let you change doctors whenever you wanted to, any hospital, so you'd be in control of your health care. They would let you change jobs without having to lose your insurance, without having to change your doctors, and no premiums, no co-pays, no deductibles, by and large, in both bills, with one little caveat that we'll get to. So they're both largely the same on these most important parts, but they're not identical. So this one has all the benefits that you would want, that we've talked about, including both bills are good. Both bills are explicit about this, about reversing the Hyde Amendment. So both bills say that full reproductive choice would be a covered benefit, that abortion care would be covered. Both bills say that. In Missouri, that's a pretty hot topic. Anyway, both bills say that, and all this other stuff. The bill in the House has a 2-year transition from the day it gets passed. The bill in the Senate is the same, except that it actually doesn't bring in nursing home care. It leaves that within Medicaid as a last vestigial remnant in Medicaid. And it has a 4-year transition, not a 2-year transition, and it actually lets Medicare Advantage to continue during that 4-year transition. They're also not identical on cost sharing, no premiums, no deductibles in the House. The Senate bill, I don't know why he's done that, but he does continue a $200 maximum copay, annual copay of $200 on pharmacy. So prescription drugs could have a maximum out-of-pocket for a year of $200 on prescription drugs, unless you're under 200% of the poverty level. And that's, in theory, designed to encourage the use of generics over brands. We could talk about that more, too, if you're interested when we get to the Q&A. They also differ on the transition. There's details, during year 1, the House would expand benefits and eliminate premiums. After year 2, it adds some age groups. In year 3, it goes live. The Senate bill expands benefits also quickly, and then, interestingly, ends the 2-year waiting period for disability. I don't know if you know about that. If you're disabled and you want to get Medicare today, you have to wait 2 years. That's a really rough 2 years. So the Senate bill eliminates that immediately. It also creates a Medicare buy-in for the transition period. This is the only way that I think a Medicare option makes sense, is when it has an ending point, and this one does. It would gradually also increase the ages, as the other bill did, and after 4 years, it would have everybody in it. I'm going to skip through provider payments, unless you're interested in that. So, last quote for me to read to you. This was from Phil de Blasio, and he was talking about schools and universal pre-K in New York City, and he made this statement: look at Social Security, look at the buy-in of Social Security. It's bipartisan, people of every region, every background, everybody in the country pretty much believes in Social Security. Obamacare, people still don't know what it is. I mean, we're 9 years into this. And Obamacare is still pretty confusing. When you tell people that it's there for you, no matter what, that it's morally right, that's not just correct strategy, it's actually a winning hand. It's actually a winning hand politically. So that's one of the main reasons, I think, to advocate for true single-payer Medicare for all, is you can just say that phrase and it defines itself almost. So when candidates say that, make sure that they support the real deal. So you can join our organization. You don't have to be a doctor. You can join PNHP. You can be sure you get on the mailing lists in the back. And we have some time for questions and answers. If you want to do Q&A, if you have questions, we'd like you to come to this mic over here. And the mic is, you don't have to have your nose right to the mic. You can be like back a little bit. But if you go over there for questions, if you have any, we have some time for discussion. Please use the mic because we're actually kind of recording this. So if you have a question or a comment, please be relatively brief. You know, don't read Dr. Seuss to us. Be relatively brief. But make some comments or questions. And then after we're done with that, for a while, we have, you guys, we have a song that I think you're going to enjoy with a bunch of local musicians that will be joining us. So it's about 5 minutes of music. Yes, please.
How are the costs of hospitals and doctors controlled?
Can't hear.
I can repeat how he said, how are the costs of doctors and hospitals controlled? Let's make sure that's on.
It's just going into the camera. It's not.
Oh, okay, well, we have another mic.
Technical difficulties, just bear with us here.
Can you figure out how to turn that on? So we can use that, both of them for the questions. So the question was, how are costs for hospitals and doctors controlled? And there's two parts to that. The hospitals, it would be different than for physicians, of course, different things. On the hospital side, that's one of the ways that the two bills differ. And the House bill is really robust about this. The most important thing, I think, for controlling hospital costs is to get away from letting them game all the details. Get away from making them nickel and dime every Band-Aid. Oh, you had 12 drops of IV fluids. Well, you only had 14, you had 14 drops. Get away from that. The way they do it in Canada, the way we do it in the fire department, the way we do it in roads, the way we do it in most other things like this, give them an annual global budget. One global budget for the country, for each hospital, and it turns out that then they can do things much more effectively. And have that budget set up so that if they want to build a CAT scanner, they can't short the nursing staff to build a new CAT scanner. So things like that for the hospital side. On the physician side, the key there is to remove the perverse incentives that make us want to do more. Physicians under this program actually come out quite well. If you look at physician salaries here versus in Canada, Canadian physicians do well. They have 25% overhead compared to our 55% overhead. Physicians for the last 15 years have been migrating from the United States to Canada. Net efflux of physicians from the United States to Canada for the last 15 years. Canadian physicians who left 20 years ago, on average, have been returning the last 15 years. So you can control physician costs without having to be really onerous and mean about it, just align things better. Anybody else?
You want me to take it? You want me to take it too?
Sure.
If you raise
Well,
your hand?
then she can't, but then she can't get it.
No.
Anybody else? Wait, can you mind coming up here? Because she's recording it, we have two mics, and I know it's awkward. Sorry. So anybody who has a question, if you're not comfortable being on camera, feel to write it down on a piece of paper and raise your hand, and one of us will come and get the piece of paper if you don't want to be on mic. Please.
Interesting. If we could list here, first, mental health parity, benefits to small businesses. The Oregon Health Plan had a situation where they had health that was given by lottery to certain demographics, and one of the things they found out was that after a couple of years was that the mental health utilization decreased to some extent for the people who actually did get the health care. I worked at the Pelican Bay Prison for some period of time, treating the patient population there. So I assume when you say resident, that will also cover incarcerated persons and perhaps the children in cages down the border.
So first, mental health parity, of course, both bills turn mental health, as it should be, into just one more part of the healthcare benefits there's nothing in either bill that talks about some unique restriction that you can only get 10 mental health visits, or you can, I'm sure there would be a regulatory process that would impact that, but mental health is treated like any other part of health because it is. There are two groups that are not included in either of the bill. The Veterans Administration remains the way it is today for the next 10 years under the bills, and Indian Affairs remains as it is today under both bills. And my understanding is that those two groups were carved out like that because those two groups said, we actually like the way things are by and large. Things need to get better, but by and large, we're happy with this, and we want to remain excluded from that. So those two groups are not in it, but it could be it would be revisited in 10 years. Inmates, incarcerated folks, absolutely would be included in this process. And my God, that's important. I don't know if you've probably run into this. I've run into this where people are in the house, in the house, incarcerated, are stabilized with medications, often for mental health medications. They're stabilized for this, and they have a certain kind of insurance coverage while they're in there. They get out, and that disappears. They're handed maybe 10 days worth of drugs for what they had, and at that point, in many states, they then have to apply for insurance, oftentimes for Medicaid. They have to go through, so there's often this gap, and even if there isn't this gap, it's a different insurance when they get out, and the drug that was saving their life or keeping them healthy in whatever way is no longer the drug that they can have any access to. So it's incredibly important, in my mind, to stop that and to make sure that people who are incarcerated are treated almost as if they were human beings and give them the same darn coverage with the same benefits and certainly the same drug formulary. So there's nothing in either of the bills that in any way contradicts that. So that's exactly, but as with anything, we would have to be careful and watchful when the regulations would be built. But yes, really important stuff. And kids in cages, different topic maybe. Those aren't cages, those are, okay. Thanks, really important stuff. Thanks for doing the work you're doing. Hey, try to use both of these mics somehow if you can.
Could be confusing, but I'll do the best I can. Can you hear me?
Closer.
I've been,
Put the one of your hand closer to your mouth.
yeah, I've been in the VA, there it is. I've been in the VA system of medical care for close to 50 years. And it's been one of the systems that has been brought up as a model for a national health care program. You don't pick your own physicians in that system, but there is a great, I would say a great continuity of care in the system. All my records are available to me online. I can order prescriptions online. I make appointments online. I get reminders online and in the mail. The system has had its ups and downs, but it works very well for me at this time. I was wondering how you see that as a possible model for a national health care program.
So I agree with everything you just said. The VA has gotten a bad rap lately because they're frankly underfunded for the rapid growth we've had in veterans for all the obvious reasons. So as a consequence of that, they have service problems, and related to that, not every veteran is allowed into the VA, but those who do get into the VA have actually some of the best health outcomes in the world, and that's really interesting that they do, because the reason that the VA has some of the best health outcomes is because once you're a veteran, you're always a veteran. So the VA learned decades ago that if they can do things today to improve the health of the veterans, 10 years from now, when they cost less because they're healthier, the VA benefits from that. That's what I mean by the aligned incentives. That's a better example even than what I did. On the other hand, in Blue Cross, or in the insurance plan that I worked for a while, when I would say, let's do this campaign that's going to improve health, let's do a colonoscopy campaign, let's make sure we get all the colonoscopies done, the answer I got was, well, how long does it take for that to do a return on investment? And the answer to that is about 10 years. You have to do that for about 10 years before it pays off. And guess what? The insurance companies know that they have 20 to 25% annual turnover every year. which means because people change jobs, people lose their job. 60 million of us every year change jobs, actually for the last several decades. 66 million last year changed jobs, fired or quit or what have you. And then another several million, I don't have a number, their employer changes what they offer. So insurance companies know that if they do something today, it's got to pay off in the next 2 years, or the odds are they will have improved the health of their competition. They are perversely punished for a campaign that improves their health, unlike the VA. The VA is the one place in the country where if you're a veteran, you're still a veteran. So that's one of the reasons it's such an it's developed into such a really good outcomes place. Why aren't we then promoting it as the solution? Because, oh my God, that would be a heavy lift. Well, that would be an even heavier lift than what we're going after. That would mean every doctor would be working directly for the government. That would be such a heavy lift. I don't think it's even. I think Medicare for all is realistic, and I don't think that would be a realistic thing to go after. But I do think theoretically that it is actually probably a terrific idea in terms of outcomes. All the evidence would support what you're suggesting.
I've heard from some friends that a completely free market healthcare system would work out to be cheaper than any government-controlled system. What do you think about that?
So this may surprise all y'all. There it is again. This may surprise all y'all, but I'm actually quite a free market supporter in many areas. And I actually think that Medicare for all is a free market solution. That's probably not what you would expect. But let me unpack that for you. As a physician, today I compete against other physicians, not for you. I compete against other physicians for the most lucrative insurance contract I can get. That's the game. And then if I find that insurance contract, and you're going to pick your doctor often because they're in the directory for that insurance contract. So if I find the insurance contract, then I'm going to have patients coming in from that for whatever reason. So to do that, if I find an insurance contract that's going to offer me $5 more for an office visit, then I'm going to have, and they say they're going to have 100 patients, I'm going to then look in my list of insurance contracts and find the one that pays the least and try to get rid of 100 of those patients. Maybe I'll cancel that insurance contract. And that's why when you go to the doctor's office and you see that little sign in the window that says, this office is no longer accepting such and such insurance, it seems like some arcane bureaucratic, thing. That's because they've decided that that group of patients is not worth enough economically to continue to treat. And we have other patients who are worth more to us economically to treat. So today, the free market with its one finger is making me compete against other doctors for the most lucrative insurance contracts, even if that means that I have to get rid of 100 patients or 1,000 patients, even if that's what that means. Under Medicare for all, single payer Medicare for all, every patient in the country would be worth the same amount to me. I would no longer have to assess what's in your wallet before I let you come into my practice. If you wanted to come see me, you could come see me. As long as I was giving you the health care that you thought you deserved and wanted and needed, you could continue to come see me. Your decision to come see me means I would get paid for taking care of you. I wouldn't have accounts receivable. Your coming to see me would work. I would want to keep you in my practice as much as I'd want to keep anybody else. I would be competing against other doctors to make my patients want to come see me. That's completely not the way it is today. So to me, this Medicare for all, single payer Medicare for all, is a much better application of the free market in healthcare.
Hi, my name's Eric. I want to say thank you for taking this all on your shoulders. I know you're supposed to have a counterpart, and that's right. So that's kind of what my question was regarding. I was hoping to get to ask the young gentleman from Democratic Socialists of America. I'm a steering committee for the Young Eco-Socialists. We're an anti-capitalist organization. And so with a lot of the statistics that you've shown, how the overhead in these privatized insurance companies are basically siphoning out so much that could be going to helping people. My question is, these same kind of models and statistics for healthcare that we're looking at can also be applied to virtually every human necessity in this country, right? So where you have a middleman, a capitalist in the middle of the situation of providing your necessities, whether it be housing, whether it be internet, whatever it may be, you have a capitalist in the middle basically taking 30 to 40% off right off the top, dumping it in their bank account, going and buying some yachts, maybe some islands and things like that. Meanwhile, we're not getting our human necessities met. Like healthcare, for instance, virtually every single other major nation, even Venezuela, has been way ahead on this stuff than our country has. So my question is, if this model shows us how much it would save us, couldn't that ultimately be applied to other portions of the economy?
I could not possibly agree with you more about that. I could not possibly agree with you more with that. And to me, and that's the slide I went kind of quickly over about the social determinants of health. To me, this is the model that could capture really all of that. Under this model, when we do this, if we discover and have evidence to show, and I think that would be pretty easy to get, that housing disasters directly drive up the cost of healthcare, that all of these other things, that bad schools directly drive up the cost of healthcare. Once we have this in place, then the country has a business case. I'm all about business cases. The country then has a business case to figure out how to solve these other problems, and I think you're right. This may very well be the model that would solve all the other things. But I think the biggest barrier is democracy. Our democracy, that's the first part of DSA. Our democracy is on the ropes here. Our problem is that pharma manufacturers and drug and device manufacturers and the insurance industry lobby so intensively, and campaigns are so expensive that our democracy is on the ropes. And to me, that's the most important thing about this: is get people to want to fight for this, get people to realize that the reason we don't have this is because of these lobbyists that are destroying our democracy, and then we can double track towards fixing both of those. And once we've done that, it becomes inescapable that we have to do some of these other things. So I think it's a really important way forward. And I agree with you about the proof points and all the other things. Thanks.
Hi, I have two questions, but they're short. So the first question is, with all the statistical and computer power that one has to get cohorts and see how things are going to work out, how do you feel insurance companies, what risk do they have, and does HIPAA help insurance companies more than individuals?
Explain what you mean by the risk. I didn't quite.
So insurance companies, they deal with risk. And so if they have good computing power and they can look at statistics, they can look at a cohort and say, okay, I know that 60 people here are gonna die or whatever, are gonna get something. And that's how I'm gonna do my insurance. I'm not taking any risk. So as a business, I'm not contributing anything to society. I'm just making money, like the other gentleman was talking about. And that has to do with an information gap. And a lot of things that HIPAA does is it doesn't let free information flow and let people know how much, what their medical records are and things of that nature. Does that make more sense?
Yeah, I don't know if y'all know, he's using the word HIPAA. I don't know if y'all know what that is. It's a law that was passed in the 1990s, I think. It's the Health Insurance Portability and Accountability Act. I think that's right. Portability and Accountability, something like that. I think that's right. And it has drastically protected patient information so that nobody but the payers or the physicians can use it, and patients often have a difficult time getting to it. But the insurance companies, you're right, have all sorts of mechanisms for getting to the data that they want. And believe me, having been on that side of it, the insurance companies are using your data. They know what magazines you buy. They know whether or not you have a TV and what channels you watch. They use all of that data. They have the power of big data and all the computing and all the IT guys, IT folks, to do this. So you're right. That's part of their power. You're right.
The other question is, we have a medical provider shortage, especially in rural areas. Is this system gonna alleviate that, or?
So that to me is one of the most powerful things about a single-payer Medicare for All program. In St. Louis, where I live, we have this world-class hospital that my mother-in-law went to, Barnes Jewish Medical Center, literally world-class, literally, and go 1 mile north from there, and you can't find a doctor. You can't find a hospital. You can't find a clinic. And go 2 miles north, and you probably can't even walk then to this hospital because, And a lot of the folks living there, they don't have a car, and the public transportation where I live is horrible. There's no train, and it's dreadful. So we have these communities within my city, and certainly when you get outside of the city, go into rural communities, we have these areas with no doctors at all, or very few doctors. And the ones that are there have no time to see patients. They have closed lists. They won't take new patients because they're overloaded. So there's a couple of important ways that this would address that. So the first thing is, if you're coming out of med school and trying to decide where you want to practice, do you want to go practice somewhere where there's already 13 doctors for every patient? Or do you want to go practice somewhere where there's no doctors for any patient, but they all have really good insurance? And guess what? If you're trying to set up where you're going to practice, you want to be the new doc in a town that's got insurance and doesn't have doctors. So it wouldn't immediately solve the problem, but it would set in place a dynamic where these currently underserved areas would become green fields, as they say in business. They'd become the place where people would want to start setting up practices. So on that basis, it would be a tremendous benefit to the rural areas. Another way that this would really help physician, we all know that there's a relative physician shortage. Well, doctors today, we're spending a third or a half of our time, or in some cases more than that, not treating patients. Some doctors are only spending 10 hours a week on administrative work, but many are spending 20 or 30 hours a week on administrative work. 30 hours a week taking care of the paperwork of the insurance industry. That makes us unhappy. We are an unhappy group of doctors in the country. And compare that 20, 30 hours a week in the United States to Canada. Canadian family physicians, Freem, I happen to know the number, Canadian family physicians average 2.4 hours per week on non-clinical administration. So what this does, of course, if you can get us down to something more civilized in terms of how much non-clinical work we have to do, we become happier. And guess what? It's not, we can work the same hours per week, but spend more of them seeing patients and be happier, and then deal with some of the shortage issues that way too. So in many ways, would Medicare for All solve every problem in healthcare? Of course not, but what's so exciting about it to me is it puts in place a system that cascades into the other things that we need to have fixed. So that's part of why I like it. I think we're probably long enough on this, unless you want to hear a song. If you want to hear a song? Yeah. Oh, one more question. Last question, then we're done. So ukers, start coming up to the front. And we have a ukulele group.
Oh, okay. So I'm curious, it seems like there's a lot of momentum right now for Medicare for All and from Canada, actually, so it's so exciting. And I'm just wondering, what do you attribute it to? I mean, I have a few ideas, but because you've been so much on the forefront of this campaign, and what would be the best strategies for us to continue to, help with bringing this to a reality?
So welcome, Kim. There's I think two main reasons that we're seeing this explosion of interest in Medicare for All. The one is Bernie Sanders. How do you not attribute it to Bernie Sanders? So that's the one. But the other that you may not have quite realized is business. So business has long seen the increasing trends on the cost of healthcare. Why haven't they taken ownership of this? They see this as a thing, as a problem. And I've gone to some of these boardrooms and tried to talk with business leaders about this, and what they tell me is that healthcare may be increasing more quickly than other things on their expenses, but healthcare 15 years ago was maybe business priority number 15, and it climbed up to number 13, and we only pay attention to the top 3. And so what we've seen over the last 15 years is this skyrocketing trend in the cost of healthcare has now made it the number 2 or number 3 driver of business expenses all over the country. And so all of a sudden, we're seeing major businesses taking proactive solutions to healthcare. So the good news is it's getting a lot worse. And we're finally the frog in the boiling water that's going to have to do something. So that's part of what can we do? What should we do now? Don't elect anyone who's voting for who says they're supporting a false flag. Don't vote for anybody who says Medicare, yada yada. If they're not, and when they say they're for Medicare for All, nail them at the town halls and find out, do you mean single payer, or are you one of these folks who just who denies the 29 studies and only pays attention to the Koch brother funded, the crazy ones. If you don't believe the 29 studies, and if you're not willing to fight for what we need to save our country, I'm going to vote for the other person. So elections, the most important thing. The most important thing is elections, which could not possibly be a better segue to the song we're going to go sing for. So let's go to that. First, I want to teach you the words to the song. What? Yeah, why don't we come up here? So we gotta sing. Okay, so here's the chorus. Vote by vote, door by door, tell them what we're fighting for. We're gonna build a solid core. Sitting out is not a choice. Door by door, town by town, we've gotta act before we drown. Don't let them tear our country down. Stand up and raise your voice. Get it? That's the chorus. You can sing with us on the chorus, sing with us on the verses if you want to. It's the old Garden song by Arlo Guthrie, maybe we'll know. So, it's actually the Garden song. Let me get mine too. We are. So my wife and I wrote these words. It dawned on us that the Garden song was a metaphor. It finally dawned on us that it was a metaphor. I thought, well, let's not make it a metaphor anymore. I know what you're thinking. Vote by vote, door by door, tell them what we're fighting for. We're gonna build a solid core. Sitting out is not a choice. Door by door, town by town, we gotta act before we drown. Don't let them bring this country down. So stand up and raise your voice. Democracy is not for sale. No time left for us to wail. Time for solidarity. We can't wait and close our eyes while our Constitution dies. Stop believing all the lies. Time to end the tyranny. How do we do it all together? Vote by vote, door by door. Tell them what we're fighting for. We're gonna build a solid core. How? Door by door, town by town. Gotta act before we drown. Let them bring this country down. Stand up and raise your voice. We'll resist with all our might, shine a light and make it bright. We cannot give up the fight, not until our work is done. So plant your feet, make a stand, send a message through the land. We all need a helping hand, we won't stop until we've won. How are we gonna do this? Vote by vote. Door by door, tell them what we're fighting for. We're gonna build a solid core. Sitting out is not a choice. How? Door by door, town by town. We gotta act before we drown. Don't let them bring this country down. So stand up and raise your voice. Town by town, state by state, we're gonna stamp out greed and hate. Don't give up, it's not too late. That's how we make our country great. And then we can all rejoice. State by state,